Heidi, incidentally, is a lady that I've seen over a few years in the office and other places, but mainly in the office, to help overcome her traumatic brain injury in a way that is completely alien to the medical community of neurologists and psychiatrists, and in fact all of medicine, doesn't understand the approach that Heidi and I have taken, which is a rather unique process of approaching the brain from the bottom up and taking into account the fact that the brain pathways are originating very close to the temporomandibular joint, which is a portion of the brain that's recently being exposed as an area that can be treated and reversed so that people that have almost demoralizing, catastrophic kinds of traumatic brain injuries can start over. And some of this information currently is being promulgated by Dr. Levine, who is, Peter Levine is a psychologist that has spent his, I don't know how many years, probably 50 years, devoted to an indirect approach to traumatic brain injury that is focused on post-traumatic stress disorder. And that's where I'm coming from, and I'd like to start here so that Yasmin can. Yasmin, incidentally, is my chief operating officer. These are things that are inadvertently opened up in a consultation with a patient. Like when I met Heidi, Heidi was, is it okay?
Yeah.
Was beset with some horrendous background information of a horrendous traumatic brain injury that she experienced in a, I'm sure she's been able to explain it to you or describe it to you, in a multiple rollover accident with a lot of trauma to her brain that she may or may not still be aware of. And I won't ask her about that either, except that if it comes up in this discussion, that you ladies see a possibility of there's a post-traumatic stress syndrome that exists in people that have a traumatic brain injury. Have you experienced that? And have you, above and beyond the post-traumatic stress syndrome, progressed into post-traumatic stress disorder, where you're now permanently engaged in a battle between the positive and negative sides of neurotransmission? Or have either of you, these two ladies I like as an example because they have the background of what we want to discuss to promote a positive feeling about treating temporomandibular jaw dysfunction, which I feel a very high percentage of our population suffer from. Whether or not they've had a traumatic brain injury or not, I feel that most people are going through the stress, hormonal stress of advancing age, and combined with some physical and mental insults that occur just by our being alive today and getting out on the freeway and then getting back home safe again. We're facing post-traumatic stress disorder as a possibility in the back of our heads that needs to be addressed by somebody. And it needs to be addressed in a way that's rather dramatic and fast. There's an awesome possibility for people that have traumatic brain injuries to nip it in the bud, so to speak, if the patient can be seen right away. And an example of that comes out in Peter Levine's book. It has two books actually that are currently bestsellers and very much related to what Yasmin and I present as a possible solution to what some of you have experienced, and which Teresa can incorporate in her putting together a lot of different things in health measures. Heidi has already got it all. She knows it from top to bottom and from bottom to top, and I can't improve on Heidi's knowledge of what's going on. What scares me is that she thinks that I have something new, but basically what we're about is interrupting nervous transmission from the brain to various parts of the body with what several recent authors have projected as just overwhelming new evidence that there is some connection between us and God that is real. That it's not based on the biology of mechanical movement, but maybe based on some sort of a deeper core being that gives us the opportunity to take a terrible experience and turn it around. And through the projection treatments of Peter Levine, as an example, this has been proved to be true. I won't delve on him, but I think there are two books that if you were interested in getting that would contribute to what Heidi projects in her group studies, but also in what Heidi has done with herself. One of the books is Releasing the Tiger Within. The other book is The Unspoken Word. And that's Peter Levine's way of saying that the connection between a victim of post-traumatic stress disorder or a calamitous incident when their life was threatened can be contained. And if the patient can stay within some treatment with someone like Peter Levine, it can be reversed. Now, where do we come into that? Yasmin and I feel that there is a nerve transmission that occurs in trauma, whether it's physical or emotional, or whether it's a physical impact or whether it was an innuendo of an insult that occurred during that accident. And most accidents have all sorts of side effects. Amongst them are, most frequently, we feel, a dislocation of the temporomandibular joint, which means that the disc that protects the condyle against the brain can be protected with some sort of an intraoral device.
Okay, well, so that's your ear canal right there, and that's the bone of the condyle, and it's bilateral. It's in both sides, and it's both sides, so it's right and left. So it's like, oh, do I have a bad joint? No, you have to have two bad ones, because one side is off, the other side by default is off, because it's all together into one piece. It's one bone that sits over there.
And oftentimes we think, well, it must entail a fracture of the jaw, but it doesn't always entail that. Or it has to be a fracture of the upper face, which it doesn't have to be, or a fracture of the skull. A traumatic brain injury can occur without any of those things happening, but usually the physical impact of a temporomandibular joint insult is catastrophic to the brain. And from that point on, unless it's treated in a way that the patient's ability to cope, ability to withstand more stress has to occur, and it has to occur fast and deep for that patient to survive a life without post-traumatic stress disorder being there for the whole rest of their life without any remission. And so the sooner that these things can intervene, and Heidi had, if I may, as a, well, not as an example, but Heidi had a lot of treatment, a lot of proposed treatment, a lot of ways of looking at what happened to her before she ever descended on my doorstep. But when she did, she started accumulating ideas that were a little different than what she'd previously been taught or educated to by her other professional advisors. And as this occurred, Heidi began to get the perception that, my goodness, anything that disrupts the temporomandibular joint in any way, shape, or form, whether it comes from a punitive announcement of a parent getting almost physical with a child, that puts a lasting impulse on the brain. And the lasting thing that stays with that patient, which becomes more problematic, much more problematic after a post-traumatic stress disorder occurs. So it's not just out on the front lines of our troops, but it's also on the front lines of our soccer moms and all the other ladies that have to contend with a rather rigid other person in the family that doesn't really understand his wife or his lover, whatever you want to call that. So this disparity between what is and what isn't needs to be redirected for that person to have some position in life so that their jaw discomfort and their unending headaches and pain in the head, neck, and shoulders and their chest and their belly, all of that has to be resolved or relieved some way, or that person isn't going to survive without a very uncomfortable life. And our intervention into this syndrome, if you like, or you can call it a disorder, the disorder can explode after a post-traumatic stress syndrome, which means that something has happened, like slipping on the steps and falling a little bit and ending on your knees, or any sort of a simple home-like accident can develop into a stress syndrome because we have a background in our brain of previous assaults. And the terrifying thing about post-traumatic stress disorder is that every patient, for example, that comes to our office, they usually come with a lot of complaints about brain injury, but if they come with no complaints at all, they've had experiences that have led them to have a disparity between a healthy brain and a somewhat rocky brain that makes it difficult for them to come to what we call the forebrain of the human being, which does all of the executive thinking, all of the decision making, all of the decision about what's right and what's wrong. And the psychiatrists and psychologists call out the dorsolateral preventral cortex. And this cortex is accompanied by another one called the ACC, the anterior cingulate cortex. And the last one is the insular cortex. All of these cortex in the brain center around a little part, and they're a little thing about a small acorn in the brain called the amygdala. And the amygdala is the forerunner of all of our ability to cope. And the amygdala can turn us around or it can make us go downhill one way or the other, depending on what sort of treatment that's afforded us.
Or lack of
In dentistry,
Or lack of treatment.
there are probably several ways to intervene this TMJ complex. One of them is orthodontics, which we don't like if we can avoid it, because it's working on, in the adult, because it's working on bones that are already fused. these bones are not likely to move ever again. And the second way is surgery, which we don't like surgery, period. But it's necessary in a lot of situations. And the third area, the psychological approach, or approach of the neurologist in feeding drugs into the person to alter or to ease the pain of their dysfunction is equally not adaptable to our practice, because our goal is to take all the drugs away, all the need for surgery, and to have a patient that starts over in life by taking a new approach to what life really means. And in traumatic brain injury, I think that's one of the big goals that you guys have, is because you've had a terrifying experience where your body has been disrupted in multiple ways, and especially the nervous system has been upset so badly that you don't have simple responses to things in your environment. You have reminders, constant reminders that there's something wrong somewhere and you don't feel right. And in some cases, people go to any extent to try to find something new or something that's revelationary that will change all of that. And Yasmin can give you some examples of this, patients that we've seen in our practice. And before I do that, before she can get into some of those fine lines, let me ask her a question. If you had a patient that came off the football field with his mom and came into the office and he was acting dizzy, and the mom said she didn't know what to do, he just got hit pretty hard out of the football field. What should she do? What would your answer be? And let me preface that with anatomical parts, which she was showing you. The condyle is the head of the lower jaw, which is the biggest survival mechanism we have. Without the mandible, without the lower jaw, none of us would survive. Because the mandible and the jaw is everything in life. We eat, drink, make love, we do everything in the spatial complex. Without it, it's not worth much. And most of us aren't going to survive too long. Now, going back to a question for Yasmin, and you can ask me questions about that kid and his mom if you want, but immediately, what would your response be to when they arrived at the office? What would you think?
What I would think is probably the long-term consequences.
Go ahead.
And actually, well, I don't want to change, but I want to tie something that you talked before. So let's stay with the kid. Well, because I want to tie up 3 or 4 different things that we hear a lot about it, and they all have a common denominator, and they are all neurological in nature. It's the brain injury, the post-traumatic stress syndrome, the neurological TMJ dysfunction, and fibromyalgia.
Okay.
And they all somewhere are what we call in the categories of comorbidity. One kinds of make the other worse and vice versa. So they all kind of go hand to hand. Not all 4 to all peoples, obviously. Some people might have 1, 2, 3, and some people have all 4. But that's why you talk so much about post-traumatic stress syndrome, because the neurological aspects of it are very, go very often hand to hand with the brain injury patients.
Would you say that when you're addressing this to the mother of this young man, you'd offer anything that could happen immediately, maybe to help him not suffer a lifetime injury, or that something in between could happen to help him? For example, is there such a thing as separating the teeth after they've been smashed together that connects the brain to that trauma? Can that be reversed or reduced through a temporomandibular type?
Yeah, of course.
Okay, how does that happen? Is it an intraoral appliance?
Yeah.
So you go ahead. What you'd be saying to the mother is,
oh, okay. Can I back up a little bit?
sure.
Okay. I want people to kind of be able to follow up in steps. So I actually wanted everybody to tell me, when we talked about the temporomandibular joint disorder or dysfunction, what kind of symptoms do you think that patient's walking into the office with? Just jaw pain, tightness. What else? Headaches, good. What else? Pain in the neck. Shoulders.
Maybe the back.
Back.
Feet.
Okay, so I'm going to give you not all, but some of the very common symptoms, and then just do a quick information, well, a quick review about when we talked about TMJ disorders. And we can talk about 3 areas. We can talk about the biomechanical part of it, which is that joint that we talked about it, and how the joint can get smashed and so forth. We'll look at that also here in the diagram. We can talk about the pain associated with it, which is all the muscles, and how the muscles create pain in different body parts, neck, back, sometimes hips, sometimes knees, sometimes even foot pain. And then the neurological part of it, which is what...
I ask you a question related to that.
Mm-hmm.
I hope I'm not distracting the flow of talk, but you're talking about all these other areas of the body that have pain. Well, can those other areas of the body have some type of injury and have referred neurological pain that causes the jaw to get more intense? So it's not necessarily just head injury that causes this, or getting your jaw whacked, but you can have an injury in some other part of the body, and it has these nerves tracing back to the jaw, and it can intensify or create the condition of a temporomandibular joint tension. So, yeah.
Very good. I think one of the things that people forget is that when they get hit in any kind of an accident in the head area, they're hitting the central process of the central sympathetic nervous system indirectly, like in fibromyalgia, which you mentioned. What would you say fibromyalgia pain would be like as corresponding to TMJ pain? Would it be similar, or would the nerve conduction be similar?
Yeah.
Because
you were talking about the same nerves.
the same nerves?
Body.
That's correct.
This is something that's very misleading today, that you go to the doctor and the doctor said, oh, I don't know anything about your neck, I'm just a head doctor, I just know about your headaches. And you go, but my hip, no, that's different doctor. And you go, but I'm one person. I mean, I can't go to 20 I'm one person. And my nervous system go from the head, top of my head to my toes. It's all the same nervous system. So it's wonderful that we have specialists and we have doctors that know about every little area. But the truth is that when we talk about a nervous system disorder, which it is fibromyalgia, which it is temporomandibular joint disorder, which it is, you know, a brain injury, you're talking about the entire body being affected. And if you don't have somebody that's looking at the entire body, we are missing something somewhere along the lines. That's why actually a lot of people would tell you, acupuncture really helps me. That's right, because they're looking at your entire body and your meridians. They're not just looking at a little part of your body.
And acupressure too.
Yeah, but a lot of the things that look as an entire body system rather than being very specific to an area are very helpful to helping patients, because we are made out of little parts, but they're all connected. Everything is connected.
And I want to add in that with brain injury, it's not just the whole neurological system, but it's cognitive, it's emotional,
That's right.
it's psychological,
That's right.
and your whole conception of yourself. All of these things are affected, and it's just a very comprehensive injury, and so it needs to be treated in a whole perspective.
Even though it's invisible.
Even though it's invisible.
That's right. That's right. Even though nobody else is seeing, your brain sees
Your
it.
brain is.
That's right. Your brain goes, I can see it. That's right.
Heidi, what do you think about some of the common medical dilemmas that people have that could be altered by taking an approach that the sympathetic system centers around the temporomandibular joint, and the sympathetic nervous system is the one that triggers an on and off, like we're turning switches on the brain. Are some of those things related to daily occurrences that might alter in the patient's total response to that pain syndrome? That's a big question.
Okay, can you minimize it?
Maybe from your own experience, it'd be better to answer it that way than to put you on the spot. I think you have a lot of background information, spending time in the office, and your curiosity has been met. You have a lot of curiosity. Writing a couple of books, you have a special curiosity about how the mind and the body interact, the mind-body thing that bothers some physicians because they're stuck with the Descartes mechanism and the Cartesian theory of pain transmission, so that they can't imagine that the brain and the body have anything together, when in fact every part of the body is affected by the neurons and the protons. Everything that occurs in an electrochemical response in the brain is transmitted by the central nervous system to every cell of the body. And if it's that complex and yet that all-encompassing, it must mean something beyond the microscope.
Well, you talk about post-traumatic stress, and that is held in the body. And I think that's really important, because people have aches and pains that they don't really know where it comes from, and the process of teach gentle Pilates, which is I'm presently being considered for teaching gentle Pilates at Sharp Hospital. And this would be an awesome thing because people with any type of neurological disorders, it's an opportunity for them to acknowledge their pains and to find a way to work through them, through the gentle Pilates, through gaining core strength and through using your breath and becoming aware of what these stressors that they hold in their bodies. So when you call it post-traumatic stress syndrome or disorder, I have to make a statement for that, because I prefer not to call it a disorder because that kind of locks it into place. Post-traumatic stress is a reality, but with our own initiative we can approach that and start to come to a closure about some of those issues. And I do believe it's something, a condition that can be worked out slowly and with determination.
Absolutely.
Well, good. Did you have an idea about an example of a patient that had just been through a very traumatic brain injury, and their initial reaction to their environment, the people around them, and what goes on in their daily life? Can you synthesize a body composite of that would say the patient would be such and such, or what would some of the symptoms that you see here would?
Okay, no, but even the symptoms that we might not be written here, and actually it's really common that we have patients basically describing a lack of well-being. And you use that terminology also, you know. We can make a feel-good appliance. Well, basically what it is, it's well-being appliance. It's something, it's a position for the jaw that allows your brain to relax, allows your brain to feel better. And that is really important because stress, it's not good for anybody. Even if you are healthy and you have no dysfunctions, disorders, or diseases of any sort that's been diagnosed, we all are subject to stress in our life. And I talk about it often with patients. Having a baby, it's wonderful, but it's very stressful. So stress, it's not even negative. If we didn't have some stress, we would lay in bed all day. Why get up, right? I mean, we have to have motivation. I mean, we have to have some stress in our life, and hopefully more of the positive ones than the negative ones. But we don't want to be in a position where we are overwhelmed. So if we can negate some of the stress, one of the common things that happen when we are under stress is clenching and grinding of the teeth. This is not good, not if we do 1 day, 1 week, or a month. But if we do day in and day out for years on end, some people end up having to have root canals and crowns in most of their teeth because they just grind them all the way down. I mean, those are extreme cases, but we see them all the time. So if we can intervene and make the brain feel more balanced, more at ease, in a more balanced place.
I'd like to say something because should I show the camera my appliance?
Go ahead.
Because this is, can you come in here? This is the appliance that Dr. Kloeffler and Yasmin are the creators of. And this is what they're talking about, that because of the grinding of the jaw, putting this appliance in, which lifts the teeth so they're not grinding on each other and grinding on nerves that send other messages other places. Your mouth is kept open, but yet you have this bracing on this mouthpiece, and what that does is it sends a neurological balancing that happens throughout the system. You know, I just had this piece made, which we left it higher up so my teeth are further apart, and I really feel that because of that, and I really like it, and I feel how this is a neurological balancing results from wearing this mouthpiece.
The appliance is a very different, well, it can be upper and lower, and it can be, I mean, there's different names for it, but basically what the appliance is doing, it's affecting your nervous system. It's giving a rest position where your brain goes, ah, that feels good, ah, that feels right. Nothing wrong with a bite guard for the right patient. I mean, I'd much rather a patient has some sort of, you know, even an athletic mouth guard that they buy in the store and put between their teeth rather than grind their teeth down. But those are a different category of patients. We are talking about patients here that have a neurological involvement, either because they had a brain injury or any of, you know, traumatic injury, I mean, anything that put them in that neurological type category patient. So it's a little different here because we are talking of appliance that's worn during the day. It's worn while she's functioning. She can wear and does wear an appliance also at night. But we are not talking about a mouth guard during the day. Unless you are playing soccer or football, why would you wear a mouth guard during the day? She's wearing an appliance. It's not.
I could wear my bite guard during the day.
Yes, but you are not getting a neurological release from that appliance because it's not made for that. It has contact in every single tooth in your mouth. Therefore, all you're doing is duplicating your bite. You're just opening your bite with your mouth guard. It's even. You have an appliance that opens your mouth all around evenly. So that appliance is great to help you not clench or grind your teeth and wear them down. What we are saying is that you can do a lot more than that with the right appliance, and it's give you some well-being. It's giving you some balancing. It's helping you with concentration. It's helping a lot of the neurological issues that a mouth guard would never do. So even though they're similar, they're very different, because one is addressing your nervous system and the other is addressing a mechanical movement of teeth on teeth grinding. And there's nothing wrong of addressing the mechanical movement, but we are going beyond that. We don't want to address the mechanical movement. We want to address the nervous system.
Yeah, any appliance momentarily, sometimes even for a few weeks, will open up that jaw relationship so the vertical dimension between the cranium and the mandible is increased, and they'll feel better. And then a little later on, if it's left that way too long, is all hell breaks loose, because the interconnections between the neurology of pain symptoms through a traumatic experience have not been addressed. And the only thing that's been addressed has been the impact of this. And people, there's a disparity of opinions, even amongst dentists, but people don't go around consciously clenching their teeth. They just don't do that. There's no point. I mean, any normal individual, even if the person has become upset psychiatrically, they're not going to grind their teeth because there's something in there that tells them, stop, don't do that. But what hasn't stopped is the neurological action of the brain accepting or not accepting that activity. That goes on and on, with or without an appliance. So there are several approaches to treating a brain injury, up to and including Botox, etc. But all of those things are treating symptoms. Until the cause is effectually changed and reversed into a healing posture so that the whole brain activity can settle down and heal, as it's happened with, I think it's happened with Heidi, and Heidi pretty much gives the impression of somebody that's a whole individual and has her act together. Well, I don't think that comes about without her applying a lot of hard work on how does she get that done. So she's seen lots of people and done lots of things to find her answer, and she still is. She'll be finding her answers forever.
After my injury, it was exacerbated, and it was really bad. And then you gave me the recommendation to get some of the knots out of my neck. That's when I found the cervical chiropractor and started seeing him to help to work out the whole thing. And now I've referred you to him, which I'm mentioning this as well because he's going to be our guest speaker in June.
I had all kinds of comments, and they're very interesting because they vary. And I had patients saying that the vision straightened out, that they see crossed without an appliance, and when they wear the appliance, they can see straight. I don't know if she's one of the patients in that video, but when she came into the office, she would have the appliance adjusted, and the way we adjust it, we'll build the lifts up, and she'll come and close down to a certain place and say, that's it. That's where I need to go, because she would say her eyes would uncross. And we would do with soft material, so when she got to the point, she would hold that, and then we'll place in hot water and get the process of the acrylic hardening. And when she was right, she was right. She'll go off for another 3 or 4 or 5 months, as long as it took her to, of course, she'll say, oh, she'll call, my eyes are crossed again. Now, if you ask me, I'm not quite sure what she meant, but for her was obvious. She knew exactly what it was, because she could tell exactly how much opening in position she needed to get her eyes crossed. The lifts get worn because you have to have something softer than your teeth. We can't make something hard because that's going to grind your teeth. So we had a patient that came with an appliance that was made out of metal from another doctor, and her teeth were ground down in her lower part of the mouth halfway through, because she continued to do whatever, and now she had an appliance that was harder than her teeth. So the appliance has to be softer so that you can grind the lifts, and when you grind the lifts, we can build the lifts. Some people, they can go 3 years with the same appliance without grinding their lives, and some people 3 weeks. It widely varied between the patients and what is their activity and what's the issues. But this is a very neurological example versus a patient that I think, you know, I gave the example the other day, that was very biomechanical. She went to Vegas, that's 30 years ago probably by now, if not more. And she went playing and she won like $40,000, $50,000, and she started jumping and screaming, you know, that she won. And when she did that, she banged her teeth down and she broke several teeth through the root. And the dentist said, "What do you want to do?" And she said, "Pull them out." Well, they're broken. She couldn't repair. That's before implants, right? She could have had a bridge. She just pulled them out. They're back teeth. I don't need them. When she first came into the office, she was holding in the walls. Her balance, she could not walk straight. She was totally out of balance. The minute we were able to give her an appliance where we put little fake teeth in the end of it, where she was missing the teeth, she was well. She actually ended up just having implants, she spent all of the money that she wanted, just about. But she had implants and replaced the teeth, and she was fine. So this is a very biomechanical, that's a clear-cut case. So it's not unusual that I'll have a patient that comes into the office and said they've been diagnosed with Meniere's disease, and once they get an appliance that works on the neurological part of it, the problem goes away. So you can have the same symptoms of several things. You can have carpal tunnel syndromes, and we have patients that have carpal tunnel surgery, and they still have the same pain because that was actually connected to the temporomandibular joint and not a true carpal tunnel syndrome, although they had the symptoms. So we can have symptoms of different diseases. That doesn't mean we have that disease.
So does the TMJ and the what's the other one?
Meniere's.
No, the TMJ and the where the body aches.
Oh, the fibromyalgia.
Okay, fibromyalgia. Do those get confused? And some people
they actually go together. They say that they are comorbid, meaning one feeds in the other and vice versa. So each one of them feed into the other disease, making them worse. So they often go together. The literature varies, but they would say in many, many articles that over 90% of fibromyalgia patients have a temporomandibular joint dysfunction.
Yeah, so which comes first?
We don't know, but they go together. They are what we call mutually provocative. This one makes the other worse, and this one makes the other worse.
So what I'm saying is one probably gets misdiagnosed.
No, not necessarily. They occur at the same time, and they feed in each other. That's very similar to people that have a car accident and have whiplash, where they had the neck whiplash injury and they had the jaw lash and a jaw whiplash injury. And a lot of times, 20 years later, those patients say, "Yeah, I'm better, but I still have." That's right, because they either got their neck treated or they got their jaw treated. They didn't get them both treated together. So each one feeds in the other and keeps making them worse. That's why for you it was important to get the neck work and the jaw work. And now you are well, or you know, you are a lot better because they work together. They're mutually provocative. So if you remove one and leave the other, you're better, but you're not as well as you could be if you treat them both together.
Do you want to show some case samples here?
Yeah. we can.
Our patient was here last year sometime, but actually it was June 1st, so we've got a follow-up here that's about 10 months along. And when we talked to you before, Kathy, we were talking about all of the musculature related to the oromandibular dystonia, which was diagnosed for you by a neurologist, correctly diagnosed incidentally, that involves the tongue. And the tongue has been a problem for almost 4 years now or more?
Almost 5.
Okay. And how did that begin?
After the bridge work I had done,
Mm-hmm.
and the doctor, the young doctor, the brand new doctor, the dentist, and
Mm-hmm.
he injected me with something he said they no longer use anymore. And
Mhm.
it took 4 or 5 shots of that before it finally numbed me where he was able to do the bridge work. And then I noticed within weeks, immediately after that, that something was off. My chewing was off, and I thought maybe the bridge wasn't correctly placed or correctly done or needed adjustment. And I kept going back to the dentist, not the same young dentist, because by then he left. He was just a visiting dentist in my regular dentist's office, and he just stayed for the summer and then continued on. So when I kept going back to the original dentist, not the one who did the work, but the office, he kept saying, no, nothing's wrong. He kept checking it. And after several visits, he kind of suggested that maybe it was in my head at that point.
Okay. Now,
So
when I first saw you, you were wearing an NTI appliance.
Right.
And it wasn't working.
It was a night thing because he thought perhaps I was grinding my teeth.
And we saw a lot of Bruck's marks on that NTI, and it apparently kicked up some symptoms that related or resembled an atypical trigeminal neuralgia. So my initial diagnosis was open, but at the same time we knew that you had an unconquerable kind of muscle activity of your tongue, and you could demonstrate that by chewing. Is that correct?
Right.
And you demonstrated that to the neurologist also? He asked you to chew something or eat? Or?
She did, yes, Angie Wang, Dr. Angie Wang.
Mhm.
But then after, before I was diagnosed, it took almost a year, a little over a year before I was properly diagnosed,
I
because
see.
I kept going from doctor to doctor, and then I was finally referred to a neurologist. But then shortly after that, because I've been chewing funny for all those years, maybe sideways chewing, that's when that little soft disc in my left joint there finally slipped and then tore, and that started even more problems.
Okay.
And that's about the point that I saw you and was referred to you by another one of your patients. And at that point I was in extreme pain because it seemed like the bone was grinding on the bone at that point, and it was very, very painful. So I think at that point is probably the time I was introduced to you. And
So when I first saw you, I was thinking about maybe say co-canalization of the throat to see if that 7th or 9th nerve was involved, and the left tongue musculature, which was hyperactive, that continuously and typical of a oromandibular dystonia. The oromandibular dystonia for you was so disabling that you lost 40 pounds? And
not quite 40, but over 10, because it was so difficult to chew, and eventually I just lost my appetite for food because that was kind of like the enemy, because it was such a struggle to try to even chew food that I lost my appetite, and I just lived on smoothies, soups, yogurt, soft things. And of course all that time I was dying for a crunchy salad or a piece of meat or whatever, anything other than the bland, soft liquids that I've been on. So I think that's what I've missed the most, and because I can't eat the foods that I enjoyed, I think I lost my appetite, and as a result I lost weight because of it too. So that's kind of a That's no
we had
problem.
some medication that we've used this past year, and I think it's been helpful to you. If you can relate what has happened with the medication that you've been taking.
The Keppra has probably been
Keppra,
working
yes.
the best for me, and just a side effect maybe being a little bit binding, it binds you a little bit, and perhaps also I think I have almost a metallic, kind of an off taste in my taste buds when I eat the food. Even drinking water, that even tastes off, so I think it may be, I don't know whether it's a residue effect or whatever, but that, and I think that also decreases my appetite for food because nothing really
Tastes right.
tastes right.
So we're talking,
But it's a good trade-off because I think overall it's probably been the better of the medications that I've been on, and versus the Neurontin?
well, no.
Or not,
this has been,
what was the other thing that we're, the pill form that you were, I forgot it was another
nortriptyline. We've done recently done nortriptyline, but that one relaxes a lot of the nerve system disorder that goes along with the muscle activity, and the nortriptyline can be increased because we have a very minimal dose right now. I forget what you have.
But I haven't taken it for months because
Okay.
once we started the
right.
Keppra,
Right.
then you told me to disregard the other.
Right.
So.
Well, we'll be revising that soon, and we'll try to get away from the thing that was a threat to you in the beginning. The thing that was a threat to you in the beginning was the possibility of Botox, and the neurologists and treating oral mandibular dystonia don't want to do that for the tongue because it would affect your swallowing and affect your ability to survive. Your breathing even is threatened by Botox in the area of the ninth nerve, specifically the glossopharyngeal nerve. Would be rather dangerous. So we haven't attempted Botox in any of those muscles, and those treatments of Botox would be great for short periods of time, and Kathy and I talked about that because after several 3-month
Then you have to do it
variations,
again.
it loses its
Right.
ability to help, or it makes it worse. So we've been delaying that by using orthotics that decrease all of the activity of the area of the trigeminal nerve attachments or relations to the temporomandibular joint, and that's where we are today.
She has no control of her tongue. Her tongue it moved a lot less. She had an appliance in when she was talking, but when she first came in, it was even hard to look at her because that's right. Her tongue was just like it had a life of its own. That's what she said. She lost taste, she couldn't eat, she lost a lot of weight, but it's very frustrating when day and night your tongue is moving around like crazy and you have no rest.
Well, it would have been fine if he would have injected, and her tongue and her jaw and the teeth all got numb. It would have stopped there. But he hit the nerve, so the nerve went dead.
Oh, it went dead.
It's irreparable.
Something like it would come back.
Yeah, no, it doesn't come back. No. I mean, we could calm down some of it, but you can still see in the video that she has a lot of tongue movement or, some unusual things.
Well, her brain and her tongue are fighting to find a position. They can't find it because the nerve's dead. So the patient directs the treatment. We don't manipulate the jaw to any position. The patient shows us the position by various phonetic tests, which involve no machinery of any kind. They just say different words for us. And we find the word that gives the exact location of that place in space, and we record it. We get that position, and then we build the appliance from there.
He can see if your tongue position is where it should be the most corrective rested position, or if the tongue is stressed. You're not going to have well-being if your tongue is not relaxed. If your tongue is stressed, you're not going to feel well. So he can look at people as they're speaking and just tell a lot about them. And patients sometimes, he says, don't pay attention to me, I'm looking at you speaking, because he just zero in his vision on the patient's mouth as the patient's speaking. And people sometimes, especially if they're young girls, you know, like 14, 15, they get really nervous. What's he looking so much at me, you know? But that's what he's looking. He's looking at your tongue movement. He's looking at your speech and where it should be.
Yeah, the tongue is a basic muscle that we use in diagnosis. It's the principal muscle because it directs speech. And speech, phonetically, is how we determine that place in space.
In her case, she ended up with a temporomandibular joint dysfunction because of all that movement that she had day and night all the time. She was biting her cheek, she was moving to one side or another. So we do a lot with our mouths, but at least most of us, it's up and down. We have some measure of normal movements. She had abnormal movements 24 hours a day for 5 years.
Oh, yeah, she had a real neuropathic disability.
Oh yeah, one shot. And
Another iatrogenic illness.
That's right. And it happens relatively often. It's not like you haven't heard of it.
Yeah.
It would have been nice if she could have had a Botox injection into her tongue or into that region. But you can't inject Botox in there without taking the chance the patient will die right there.
Oh.
So you don't inject Botox in the mouth.
A lot of times patients have symptoms of a disease. It doesn't mean they have the disease. I can have patients come in and said, I've been diagnosed with Meniere's disease, and we give them an appliance and the dizziness go away. So they truly didn't have the Meniere's disease, but we have patients that do have it.
I missed out.
Well, no, we're talking about having symptoms of a disease and having the disease itself. Sometimes patients have symptoms like Meniere's. They don't necessarily have Meniere's.
Meniere's and TMJ are two intermingled disease concepts. One concept is from the ENT doctor, ear, nose, and throat. He has he can zero in on Meniere's. The dentist can zero in on the exact same signs and symptoms of Meniere's and say it isn't Meniere's, it's TMJ. They're in no man's land. It's neither a TMJ expert or an ENT expert. It's the eustachian tube that defines that. You can look at the eustachian tube way up here in the corner of your mouth and find out where it enters into your mouth, under your tongue. And if it's not obstructed, then it's not Meniere's.
If a person has issues in relating to this tongue, the tongue being, it comes all the way down here, right?
How far the tongue muscle goes?
Well, it's anchored under the manubrium, under here, clear down here.
The manubrium?
Yeah.
Where's that?
Right there. No, up. There you go.
Mm-hmm.
Oh,
Right there, that little bone.
The epiglottis is right above your phonation area, where you form words. Like what we like is 66. It's a sibilant sound that describes the place in space that we build the appliance from there.
So if I say 66, and then you're looking at what? And what does that tell you about my tongue?
He's looking at your tongue position. on the 66.
A 55, easy. You can do that, 55.
55.
But try 66.
66.
There's a lot more stress to the tongue on the 66 than it is on 55.
Or she sells seashells down by the seashore.
That's
Yeah.
right, that's the same, that's the S sibling sounds. Yeah. He can determine the vertical of dimension. He can determine how high your lifts are going to be or how low they're going to be according to the phonetics, the sounds that come from your tongue. So if a patient says, oh, I like it, he says 66 and it sounds a certain way, he said, it's too high, I need to close that down.
But we can't find that place on a CAT scan. And we can't find it on an MRI.
It's an active place. It's just by your speech sound, it can, you know, that's why he has to look and listen.
It's the muscles of speech. That's the whole deal. Well, we've had a very good time today with Barry being our background host.
Okay.
Okay. Thank you very much.
Thank you.
Thank you very much.